So describe what you see in this video.
Yes, in this video, I can see an olive-shaped mass which is present in the. In this video, I can see a child, an infant who is in the hospital setting, and he's connected to the monitor, and he is in a sleeping position and having an olive-shaped mass which is rotating all around his abdomen. My most probable diagnosis. This is a case of pyloric stenosis.
Any DD you want to keep?
Yeah, this could be any volvulus, any intestinal obstruction, intestinal wall rotation, GERD.
Mm,
Yeah.
yes, yes. So in this video, what I see, I can see an infant who is on hospital setting. Infant is connected to monitor, but we are not seeing infant face, just abdomen is showing. But in abdomen, we are seeing there is an olive-shaped mass. Direction of movement of this left to right and hydration status of the child. Remember, the movement is left to right. That is need to comment. So it is a case of pyloric stenosis. Pyloric stenosis mainly boys more affected than girls. 2 to 10 weeks of age runs in families. It is a multifactorial inheritance. So pyloric stenosis on my top diagnosis. What are the differential diagnosis we can keep like volvulus, intestinal obstruction, intestinal malrotation, gastroesophageal reflux disease, cow's milk protein intolerance, gastroenteritis with dehydrations. These are so mainly volvulus, intestinal malnutrition, intestinal obstructions, GERD, cow milk protein energy. These are. So what history would like to ask?
Yeah, I would like to ask about the onset, course, and duration. And is it a gradual onset or acute onset, or about the vomiting? Is it forceful vomiting, or what is the onset of the vomiting? And what about the content of vomitus? Is it green color or no? And is it associated with meals and any association with fever, weight loss, activity? And what about sleep and um, family history of similar condition?
Yes. So we keep in our mind pyloric stenosis (DD) in our mind, then taking the history as usual. Beginning, onset, course, and duration. What increase and what decrease, usually gradually and progressively. Then we know that pyloric stenosis vomiting is the cardinal feature. There is some changes. So vomiting is forceful or not, hitting the wall. Onset of the vomiting, if immediate after the meals. Color of the vomiters, non-bilious if green, so intestinal obstruction and its content. Intestinal obstruction also come on the video stations, and recently it comes. So if there is green vomiting, that is intestinal obstruction. That is mainly vomiting. Vomiting will be food contained, and it's just hitting the wall. Forceful vomiting, we know that just after meal, and vomiting after each feed. Yes, after each feed. Is he hungry after each feed? Yes, the child become very much hungry after feeding. Weight and height and comment on the growth chart. Then number of the diaper change per day, because dehydration we are searching. Number of diaper change per day, any blood in the stool, type of milk and its amount in each feed, and no number of feeds per day. Then family history of similar condition, because we know it is a multifactorial inheritance, more in males, male in female ratio is 4 in 1. And antibiotic taken in neonatal period. Why? Because erythromycin. We think that pyloric stenosis aggravates, so antibiotic taken in neonatal period. What examination we do?
Yeah, in investigation, we would like to check for the patency of the airway, breathing, connect to the monitor, check for saturation, any capillary fill time perfusion is okay or no, dehydration, check for the dextrose level of the child. I will check for the random blood sugar of the child and check for the hydration status. Is he associated with any sunken eyes, skin turgor? And dryness of the mouth and
Yes. So
yeah.
the examination, airway, breathing, circulation, dehydration status here very important because vomiting related. Assess the hydration status. How can we do that? Shanker anterior fontanelle, skin target test, shanken eyes, dryness of the mouth, no tears. Then feeding test very important and check response. Feeding test, we know that after feeding they vomit and forceful vomiting, hitting opposite wall. Then general examination for any pigmentation, because congenital adrenal hyperplasia, our one of the suspicion, and random blood sugar we can do RBS. So ABC, hydration status, feeding test, check response, in general examination for any pigmentation, RBS. So RBS is investigations. Okay. What is the investigation do? Remember, RBS is investigation, it's not examinations. Okay.
Okay, okay, yeah, yeah, yeah.
So tell
The
me.
investigations, I would like to go for the lab and imaging. For lab, full blood count, random blood sugar level, and ABGs of the child, and urea electrolytes. For hypokalemic, hypochloremic metabolic alkalosis, and imaging of the child, like ultrasound of the abdomen.
Yes, yes. So investigation we are doing full blood count, lab, random blood sugar, ABG and urea electrolyte. Electrolyte finding is very important here. That is hyponatremic, hypokalemic, hypochloremic, metabolic alkalosis. We all know that. And ultrasound of the brain we can do. Length is more than 17 millimeter and thickness is more than 4 millimeter. Except the barium, the sting sign or mushroom sign. So mainly we are doing full blood count RBS. There is urea electrolyte. Electrolyte very important. We know that is hyponatremic, hypochloremic, hypometabolic alkalosis. ABG we can do. Our ultrasound of the abdomen, X-ray of the abdomen. Ultrasound abdomen thickness increase. X-ray there is mushroom sign. How can you manage this? Very important. Ask me, tell me.
Yeah, I will keep the child NPO. I will admit the child, keep the child NPO, insert the NGT, and start IV fluids for the child, and check for the ABGs, and correction of electrolytes within 48 hours.
Yes. Here, fluid calculation is very important because it comes on communications. Let's talk with a medical student about the fluid calculation of pyloric stenosis. I'm telling that is. First, I will admit this child. Okay, stop oral intake, nothing per oral. Insert an NG tube and aspiration hourly and test fit. So, NPO giving an NG tube and all the secretions, everything I am counting. Then IV fluid. How can IV fluid first? If there is metabolic alkalosis, I give the fluid 150 ml per kg of 0.9% sodium chloride plus 5% dextrose plus 10 millimole potassium chloride and repeat ABG every 12 hours. So when metabolic alkalosis, we are giving 150 ml per kg, 0.9% sodium chloride plus 5% dextrose plus, remember, plus 10 millimole potassium chloride and repeat ABG every 12 hourly. Everything is plus. But there is no metabolic alkalosis. Now fluid will be reduced 120 ml per kg per day of 0.9% sodium chloride plus 5% dextrose and minus 10 millimole potassium chloride in ABG daily. Here ABG daily minus 10 millimole potassium chloride and 120 ml. Now aim to fully correct the fluid and electrolyte within 48 hours. Our aim is chloride will be more than 100 millimole per liter, bicarbonate will be less than 28 millimole per liter and potassium more than 3.5 millimole per liter. When we full correction done, achievement convert to maintenance fluid, that is 100 ml per kg per day. Surgery we are doing after that, that is Ramstead pyloromyotomy, open surgery or laparoscopic pyloromyotomy. So it's just Ramstead pyloromyotomy. Feeding restarted just 6 to 12 hours and discharge within 48 hours. If the patient is stable and not tolerating feeds, good prognosis. So Ramstead pyloromyotomy, they ask when you start the feeding, 12 to 6 to 12 hours and discharge 48 hours. Prognosis is good. Multidisciplinary team is consultant pediatrician, gastroenterologist, pediatric surgeon, anesthesia. Management, I'm telling you. First NPO, give the IV, NG fluid, NG suctions, and all the secretion I will be make out. Then IV give the IV fluid. If there is metabolic alkalosis, I am giving 150 ml, 0.9% sodium chloride plus 5% dextrose plus 10 millimole potassium chloride and 12 hourly ABG. Then if no metabolic alkalosis, I do 120 ml 120 ml 0.9% sodium chloride plus 5% dextrose minus 10 millimole potassium chloride and ABG do the daily. And when my aim is for chloride will be more than 100 millimole per liter, sodium bicarbonate will be less than 20 millimole per liter, potassium will be more than 3.5 millimole per liter. And when I achieve this electrolyte, then I am giving the fluid 100 ml per kg per day. And then Ramstead pyloromyotomy, surgical done 6 to 12 hours after the operation. We are giving the feeding started after 48-hour discharge. Prognosis is good. Multidisciplinary team, I will involve the my consultant pediatrician, pediatric surgeon, anesthetist if needed, and gastroenterologist. Okay, this is all about. Thank you very much.
Okay, thank you so much, doctor.